Good morning, my dear. I'm Dr. Alaa Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today about anatomy of the female reproductive system. So, what we wanna to know about anatomy of reproductive system? We wanted to outline the anatomy of the female reproductive system from external to internal and including the vulva, vagina, uterus and cervix, fallopian tubes, and the ovaries. Okay, let us start our journey. Please look to this picture, including the whole reproductive system in female, starting from the external genitalia here, to the vagina here, then the cervix, uterine cavity, fallopian tubes or uterine tubes, then ovaries or gonads on both sides related to the femoral end of the tube. The lining epithelium is different in each part. In the vulva, skin stratified squamous epithelium, vagina stratified squamous epithelium, portion of the cervix stratified squamous epithelium, endocervix columnar epithelium, endometrial lining is glandular epithelium, columnar epithelium, fallopian tubes, columnar epithelium, ciliated, and the ovaries has surface epithelium, cuboidal epithelium, then cortex containing the follicles, then medullary portion containing the loose connective tissue and the neurovascular supply. Okay. So this is the female reproductive system, and we will start first with the vulva. As you see in this picture, this is the vulva, which is considered the external female genitalia. Its function is to protect the internal female reproductive tract from infection because it is partially closing it, act as a sensory tissue during sexual intercourse because it carry sensory nerves and very rich in sensation, especially in the glands of the clitoris here and in the labia minora specifically. Also, it assists in micturition by directing the flow of urine. As you see in the picture, here is the mons veneris, here is the labia majora, hairy, here is the labia minora, delicate skin, and here is the fourchette, okay, and here is the posterior commissure, and let us speak about everything in details. Okay, let us start with the mons pubis. This is the mons pubis, pad of fat, covered by skin. This skin is hairy. It acts as a coital buffer, preventing pubic bones from impinging against each other during sexual act. This is mons pubis. What about the labia majora? This is the labia majora on each side. Two hair-bearing external skin folds extend from mons pubis as you see in the picture here till reaching here the posterior commissure, meeting each other here, forming the posterior commissure, which is a depression over the perineal body. Okay, so this is the labia majora. This one is the labia majora. Okay, it is hairy, as you see. What about labia minor? The inner skin folds here on both sides is called labia minor. It is medial to the labia majora. It is non-hairy. It consists of core of sponge tissue with blood vessels and sensory nerve endings. They fuse anteriorly to form the frenulum. This part is called the frenulum. This folds is called the frenulum, and this part is called the prepuce. So they fuse anteriorly to form the frenulum and the prepuce. This prepuce covering the glands of clitoris partially, or it's called also hood. clitoris hood, okay, or prepuce of the clitoris. Okay, this is anteriorly. What about posteriorly? They meet each other posteriorly to form the fourchette, okay, creating a fold of skin here. It's called the fourchette. So this skin folds very sensitive, so it is important during sexual intercourse and sexual arousal. Okay, this is when you try to open both labia, opening the labia, retracting them to each side to open the vestibule, to see the vestibule, which is rectangular in shape, and the four opening inside the vestibule: the external urethral meatus, the vaginal opening, and two porcelain ducts open inside the vagina. So separation of the labia to see the vestibule. This is the anterior view. This is anterolateral view, and this is the bulb of the vestibule in each side. Let us continue. This is the vestibule, as you see the picture. It contains four opening: external urethral meatus, vaginal opening, two opening of the ducts of porcelain. This is a porcelain ducts deeply embedded inside the labia majora. Its ducts open here in the vestibule. Okay, porcelain glands, as you see in this picture, on each side, secreting mucus, help in lubrication during sexual intercourse. And if this duct is closed, obstructed for any reason, it will cause porcelain cyst, and if infected, will cause porcelain abscess. What about the clitoris? The clitoris is the organ here in the midline, in front of the symphysis pubis, located under the clitoral hood or prepuce. Okay, you can see it here. This is the clitoris and this is the prepuce. It is formed of erectile corpora cavernosa tissue, which becomes engorged with blood during sexual stimulation, and this is the most sensitive part of the female genital organs. Okay, the hymen here in a version, you can see the hymen with different shape and size, as you see, variable in size and shape. It is an opening inside skin fold formed of stratified squamous epithelium. Okay, and the hymen differ in its thickness between females, and it partially closing the vaginal entrance. What about the bulb of the vestibule? As in this picture, the bulb of the vestibule in each side here, it forms two bulbs of erectile tissue deep in the substance of the labia majora. They encircle the vaginal introitus. Sexual excitement leading to contraction of the bulbo cavernosus that compress the veins draining the vestibular bulbs. That's why it becomes congested. Okay. What about the Skin's tubules? Skin's tubules, two paraurethral tubules that open in the floor of the urethra, few millimeters from external urethral meatus, and you can see in this picture the Skin's gland and the external urethral meatus, and the Skin's tubules open in the floor of the urethra. Okay, and this is of course the vaginal opening, and this is the external urethral meatus, as this is the Skin's gland. So we have two paraurethral tubules. Okay, let's continue with the arterial supply of the vulva from birth, internal and external pudendal arteries, branches of the internal iliac artery and the femoral artery respectively. Okay, so The venous drainage also via the pudendal veins with the smaller labial veins contributing as tributaries. Lymph drainage, as in the picture, drain to the superficial inguinal lymph nodes, as you see here, mostly, but as regard the clitoris, to the presymphysial plexus, to vesicle, to the iliac lymph nodes, and also to obturator lymph nodes, and the drainage from superficial inguinal lymph nodes to the deep inguinal lymph nodes, and also to the iliac lymph nodes. It's important, of course, to know the lymph drainage of the vulva because it is very important in staging of cancer vulva. What about the nerve supply? The ilioinguinal nerve, genital branch of the genitofemoral nerve, giving the anterior part of the vulva, as you see here. This is the anterior part of the vulva, ilioinguinal nerve, and genital branch of the genitofemoral nerve. While the posterior part, innervated by posterior cutaneous nerve of the thigh and the perineal branch of the pudendal nerve. It's important to know that the clitoris and the vestibule also receive parasympathetic innervation from the cavernous nerves derived from the uterovaginal plexus. Let us go to the vagina. The vagina is distensible, muscular tube, as you see in the picture, which extend posterior-superiorly from the external vaginal orifice to the cervix. It has several routes. Of course, it is a pathway to the menstruation every cycle, so menstrual fluid can pass through it to the outside. Also, during intercourse, it receives the male organ and ejaculate, and this ejaculate will be transported through this vagina to the cervix and the uterine cavity. Also, it is important as a channel for delivery, okay, of newborn from the uterus. This is a natural pathway of delivery is the vagina, and it is distensible organ allowing the delivery in case of normal labor. Okay. The vagina, as we said, as you see in this picture, is fibromuscular tube with anterior and posterior wall. The shape of the vagina is like letter H lying on a side. At the upper ending, the vagina surrounds the cervix, as you see here, forming fornices, posterior fornix and the anterior fornix, and the lateral fornices. Okay, the posterior fornix is important. Why? Because it is a natural reservoir for ejaculate. Okay, so the semen take time to becomes liquefied. This semen needs time to be liquefied, about 20 minutes. So it is a good reservoir, the posterior fornix, and why liquefaction to make it the semen or sperms easy permeating through the cervical canal, can penetrate the cervical mucus and thus through the cervical canal to the uterine cavity. So this is one of the important rule of the posterior fornix here during intercourse. What is the relation of the vagina? Anterior, posterior, and the lateral. Anteriorly, there is a bladder, as in this picture, and the urethra. Posteriorly, from above downward, the Douglas pouch, okay, then the rectum, then the perineal body in the lower third, okay. What about the lateral? Lateral to the vagina, the ureter and the levator ani muscles. Ligaments give support to the vagina and the muscles and the fascia. So ligaments like that supporting the cervix, like pubocervical, Mackenrode, and uterosacral, can also support the upper part of the vagina or the vaginal wall. Levator ani muscle, specifically the pubovaginalis, gives support to the vagina also, surrounding the vagina. Triangular ligament, perineal membrane, and the vaginal fascia. The vaginal fascia may be vesicovaginal or rectovaginal fascia. Okay? Between the vagina and the bladder is called the vesicovaginal fascia, and between the rectum and the vagina is called the rectovaginal fascia, also gives support. Why the vagina needs support? To avoid the descent or disturbance of the anatomical position of the vagina. Okay? What is the histology of the vagina? Please look to the picture. From inside to outside, the epithelium, which is stratified squamous epithelium. Okay? We call it vaginal mucosa or vaginal skin, stratified squamous epithelium. Then elastic lamina propria. Here, you can see it here. Sorry, here. Elastic lamina propria. A dense connective tissue layer which projects papillae into the overlying epithelium. Then, after the lamina propria, there is fibromuscular layer. This is the muscle layer. Okay, and down here the muscle layer. Here you can see it. And the muscle layer, two layers, inner circular and outer longitudinal. Inner circular and outer longitudinal. Okay, clear in this picture. Then, lastly, the adventitia. Adventitia is the fibrous layer which provides additional strength to the vagina, while it's also binding it to surrounding structures. So we have vaginal mucosa or skin or vaginal skin, then lamina propria, then after the lamina propria is the lamina propria, there is muscular layer, inner circular and outer longitudinal, then the adventitia. Okay. The arterial supply to the vagina, as you see in the picture, the vaginal artery arising from the internal iliac, and uterine artery also supplying the upper part of the vagina, arising from internal iliac also, and the internal duodenal artery. What about the venous return? Follow the vaginal venous plexus, which drain into internal iliac vein to the uterine via the uterine vein. Lymphatic drainage divided into three sections: superior, middle, and the inferior. Superior drain to external iliac nodes. Middle drain into internal iliac nodes, and inferior drain into superficial inguinal lymph nodes. What is the innervation of the vagina? Predominantly autonomic nervous system. Parasympathetic and sympathetic nerves, as you see in the picture, arise from the uterovaginal nerve plexus. The inferior fifth of the vagina receives somatic innervation. This is via branch of the pudendal nerve, the deep perineal nerve. So, what about the uterus? The uterus, as you see in the picture, this is a laparoscopic picture, is a thick-walled muscular organ, pear-shaped. The diameter is about 8 cm in length, 5 cm in width, 3 cm in thickness on average, capable of expansion to accommodate the growing fetus if pregnancy happens. It is connected distally to the vagina and laterally to the uterine tubes. The uterus has three parts, as you see in the picture here. This is the fundus, top of the uterus, above entry point of the uterine tubes. This is called the fundus. And the body, this is the body, usual site for implantation of the blastocyst in the body. Cervix is the lower part, as you see in this picture, in the speculum examination. This is a portion of the cervix, lower part of the uterus, linking it with the vagina. As you see, this is portion and the external os connected to the vagina. This part is structurally and functionally different to the rest of the uterus. Okay, you should know about this. Let us start with the cervix, the lower portion of the uterus. Look to this picture, please. You have here the anatomical internal os, and here the histological internal os, and here is the external os. Okay, the distance between anatomical internal os and histological internal os is called the isthmus. It is about 0.5 centimeter. This is important because during pregnancy, this will form the lower uterine segment and will be reach the maximum length late in pregnancy, reaching up to 10 centimeter in the last month. Okay, so this is the isthmus, this is the endocervical canal, and this is the anatomical internal os, and this is the external os. This is the ectocervix projecting inside the vagina, and it is lined by stratified squamous epithelium, non-keratinized. This is the opening of the cervix, the external os, slat-shaped in multipara and round in nullipara. And inside the endocervix is a endocervical canal here, lined by columnar epithelium. So the portion is lined by stratified, while the endocervix is lined by columnar. So I have a squamocolumnar juncture in this part. I have a primary and the secondary squamocolumnar junction. And this is the distance between primary and the secondary is called transformation zone, which is a very active area and the most serious part as regard the possibility of occurrence of CIN, cervical intraepithelial neoplasia, and the most important part to be screened in the cervix. Okay, the columnar epithelium inside the endocervix secreting mucus, and this mucus change in about the being viscous or viscid or more thick according to the which part of the cycle is it, follicular or luteal, under the effect of estrogen hormone or progesterone hormone. Under the effect of estrogen hormone, it is more watery and reach the maximum being more watery to allow permeation of the sperms at the time of ovulation because of high estrogen or peak of estrogen near the mid-cycle, and during the luteal phase under the effect of progesterone becomes thick, forming the thick viscid mucus plug. Okay, so these changes occur under the effect of hormones, and this, as you see in the picture, this is squamocolumnar junction, this is columnar epithelium, and this is stratified squamous epithelium, and this is the junction. The cervix performs two main functions: facilitate the passage of sperms into the uterine cavity at the time of ovulation, also protect uterine cavity and the upper genital tract by preventing bacterial invasion through closure of the lumen by the cervical mucus plug. What is the anatomical position of the uterus? Most commonly, the uterus is anteverted, anteflexed. What does it mean? Anteverted means that the longitudinal axis of this cervix making the right angle with the longitudinal axis of the vagina, 90 degree, as you see. This is anteverted. So this is the anteverted. What is the anteflexed? The body of the uterus bent forward, so there is an angle between the body of the uterus and longitudinal axis of the cervix, making an obtuse angle of 170. So this is called antiflexive. 85% of females or more are antiverted antiflexed, but 10 or 15% of females are retroverted flexed uterus, as in this picture. The uterus is painted backward towards the sacrum, and there is 3 degrees of RVF, retroverted flexed, grade 1, grade 2, grade 3, according to, is it directed towards sacral promontory, the fundus directed towards the sacral promontory, or the sacral concavity, or the tip of the sacrum. This is the severest degree of retroverted flexed uterus. So this is the RVF, and this is the AVF. This is the antiverted flexed, which is more common. You should know that the uterus normally lies posterior superior to the bladder and anterior to the rectum, as you see here, anterior to the rectum and posterior superior to the bladder. What is the ligaments in the female genital organs? Broad ligament. This is the double layer of peritoneum attaching the side of the uterus to the pelvis. The round ligament, as you see in the picture, this is the round ligament, a remnant of gubernaculum extending from uterine horns to the labia majora via the inguinal canal. Okay, this is the round ligament. Ovarian ligament, this is the ovarian ligament in the picture, connecting the ovary to the uterus here, the back. Okay. Cardinal ligaments located at the base of the broad ligament. The cardinal, this is the cardinal ligament. This is a very strong ligament, by the way. Give good support to the uterus and cervix and the upper part of the vagina. Cardinal ligament or McInnes ligaments. From the cervix to the lateral pelvic wall. Uterosacral ligament extended from the cervix to the sacrum. This is called uterosacral ligament, as in this picture. This is the uterosacral ligament, one on each side. What about the broad ligament? Broad ligament divided into 3 regions. Please look to this picture. I have 3 regions here. Mesometrium, this part, this is the largest part of the broad ligament. Meso-ovarian, related to the ovary, attached to the ovary, at the hilar region. And the mesosalpinx, related to the fallopian tubes. Let us know more about them. Mesometrium surrounds the uterus and is considered the largest part of the broad ligament. Run laterally, as you see. Cover the external iliac vessels. The mesometrium also includes the proximal part of the round ligament. What about the meso-ovarium? Part of the broad ligament associated with the ovaries. It projects from the posterior surface of the broad ligament and attaches to the hilum of the ovary, in which the neurovascular supply goes through it. It doesn't, however, cover the surface of the ovary itself. It doesn't cover the ovary itself. Okay. What about the mesosalpinx? Originates superiorly to the meso-ovarium. This is meso-ovarium. This is the mesosalpinx, including the fallopian tubes, as you see. Including the fallopian tube, as you see here. Okay. So the broad ligament is related to many structures within the female pelvis, attached to uterus, fallopian tubes, and ovaries. These organs are supplied by the ovarian and uterine vessels, which are also contained with the broad ligaments. Okay. There is 3 other ligaments inside the broad ligaments, which is ovarian ligament, round ligament, and suspensory ligament. So ovarian ligament is this one, and the round ligament is this one, and suspensory ligament is this one. Another 3 ligament inside the broad ligament. Okay. It has the uterus in its relation. The uterus has superior surface, which is convex, directed forward, anterior surface, which is flat and related to, in its upper part, to uterovesical pouch, the pouch between the uterus and the bladder, and the lower part to the bladder triangle. What about the posterior surface? As you see, it is convex and it is related to pelvic colon, rectum, coils of small intestine, Douglas pouch, and uterosacral ligament to the back. Also, the uterus has two lateral borders on each side related to broad ligament and its content, as we mentioned before. What is the histological structure of the uterus? Please look to the picture from inside to outside, from inside the cavity of the uterus to the outside. This is the cellular lining, glandular cell, columnar epithelium with glandular pattern. Okay, and you can say this endometrium is divided into deep stratum basalis and superficial stratum functionalis. Basalis will do the regeneration function after shedding of the endometrium during menstrual flow, each cycle. So regeneration occurs from the basalis 1. Okay. So this is the endometrium. Then from inside to outside, the myometrium, which is formed of 3 layers of a smooth muscle. Then the peritoneum, covering a double layered membrane continuous with the abdominal peritoneum. Also, we can call it perimetrium. Okay, so I have endometrium, myometrium, and the perimetrium. This is the histological structure of the uterus. What about the vascular supply? The blood supply to the uterus via uterine vessels, which is branch of anterior division of internal iliac artery. Venous drainage is via plexus in the broad ligament, and that drains to uterine veins. Lymphatic drainage of the uterus is via the iliac, sacral, aortic, and inguinal lymph nodes. What is the nerve supply to the uterus? Sympathetic nerve fibers of the uterus arise from uterovaginal plexus. This is the uterovaginal plexus. This largely comprises the anterior and the intermediate part of the inferior hypogastric plexus. Also, parasympathetic fibers of the uterus derive it from sacral 2 to sacral 4. Okay. The cervix is largely innervated by the inferior nerve fibers of the uterovaginal plexus. Okay. And the afferent fibers mostly ascend through the inferior hypogastric plexus to enter the spinal cord via thoracic 10, 11, 12, and the lumbar 1, as in this picture. Okay. So let us go to the fallopian tube, which is G-shaped, as you see in the picture here. This is the fallopian tube, the right one and the left one. 10 to 12 centimeter, lie in the upper border of the broad ligament, extending lateral from the uterus, opening into the abdominal cavity near the ovaries. This is the ovaries, the right ovary and the left ovary. Okay. The main function of the uterine tube is to assist the transfer and the transport of the ovum from the ovary to the uterus. Histologically, there is inner mucosa, then the smooth muscle layer. Inner mucosa, as you see here, lined with ciliated columnar epithelium and big cells, which is non-ciliated secretory cells. They waft the ovum toward the uterus and supply it with nutrients. Then smooth muscle layer contract to assist the transportation of the ova and sperm. Muscle is sensitive to sex steroids, and thus peristalsis is greatest when estrogen levels are high. So you can say that the fallopian tubes have 5 parts. Please look to the picture. Fimbria, which is finger-like projections, okay, which capture the ovum from the surface of the ovary, okay. Then the infundibulum, which is funnel shape opening near the ovary, which to which the fimbria are attached. This is the infundibulum. Then the ambulatory portion, this is the widest portion of the fallopian tube in which fertilization occurs. Then the isthmus, this is a narrow part, narrow section or area of the fallopian tube. This is the isthmus, connecting the ambulatory portion to the interstitial portion, which is the last part of the tube, which enters through the muscle wall of the uterus and connecting to the uterine cavity. The arterial supply of the fallopian tube via uterine and ovarian arteries, and venous drainage is via also uterine and ovarian veins, as you see in the pictures. Lymphatic drainage is via iliac, sacral, and aortic lymph nodes. The uterine tube receives innervation, both sympathetic and parasympathetic innervation via nerve fibers from the ovarian and uterine plexus. Sensory afferent fibers run from thoracic 11 up to lumbar 1, from thoracic 11 to up to lumbar 1, okay? What about the female gonads? The ovaries, as you see in the picture, paired oval organs located in the lateral wall of each side of the pelvis in the ovarian fossa, attached to the posterior surface of the uterus, as you see here, with the utero-ovarian ligament, okay? And also attached to the broad ligament via the mesoovarium, through which neurovascular structure entered to the ovary through the mesoovarium here. The main function of the ovaries are the production of oocytes in preparation for fertilization, also production of sex steroid hormone, estrogen, and progesterone under the effect of pituitary gonadotropins FSH and LH. Also, granulosa cell secretes other hormones like inhibin and activin hormones. What is the histological feature of the ovary? Please look to the picture. We have surface epithelium, which is cuboidal epithelium, known as germinal epithelium. Under this epithelium, there is capsule, connective tissue capsule. Then the cortex. The cortex is the area where the follicles grow, from the primordial follicles to pre-anterar follicles to anterar follicles to reach pre-ovulatory and mature Graafian follicle, then ovulation, then corpus luteum formation, corpus albicans, and so on. So this is the cortex containing these follicles. Then the medulla, which is formed of loose connective tissue and rich in neurovascular network, which enter via the hilum of the ovary through the mesoovarium. Okay, this is the medulla. So we have surface epithelium, cortex, and the medulla. Two peritoneal ligaments attached to the ovary, suspensory ligament, which is fold of peritoneum extending from mesoovarium to the pelvic wall, contain neurovascular structure. It's also called the infundibulopelvic ligament. Ovarian ligament extend from the ovary to the fundus, as you see here, from the ovary to the fundus, the back of the uterus. Okay, and this ovarian ligament, its continuation is around the ligament which extend from the anterior surface of the uterus to the inguinal canal, reaching deep in the labia majora. And this is homologous to gubernaculum in male. And during development, in early life of fetal development, it was one ligament, the round ligament and the ovarian ligament. Okay, but now it divides into two ligaments, ovarian and round ligament. So, what about the vascular and nerve supply to the ovary? Main supply to the ovary is the ovarian vessel arising from abdominal aorta. Also, rather than ovarian, some tributaries coming from uterine artery, especially at the cornea, where uterovarian anastomosis and the plexus here. Venous drainage by paired ovarian veins. The left ovarian vein drain into left renal vein, and the right ovarian vein drain directly to the inferior vena cava. Please notice this difference. Lymphatics from the ovary drain to the para-aortic nodes. The ovaries receive sympathetic and the parasympathetic innervation from the ovarian and uterine plexus, respectively. The nerves reach the ovaries via suspensory ligament of the ovary to enter the ovary at the hilum. So, lastly, I wanted to refresh your mind about the development of the external genitalia. We wanted to remember that the clitoris developed from the genital tubercle. This is the clitoris developed from the genital tubercle, this one. And the labia minora developed from urethral folds. This is the urethral folds, will be the labia minora. And labia majora developed from the genital swellings. This is the genital swellings. Okay, so genital tubercle form the clitoris, and the homologous in male is the penis. And urethral form will form the labia minora, and the homologous in male is urethral, penile urethra. And genital swellings, this one and this one, will form the labia majora in female here, and in male will form the scrotum. And the development of the fallopian tubes, uterus, and the vagina from Mullerian ducts, as you see in this picture. This is the Mullerian duct, the brown one. Okay, and this is the mesonephric duct. The Mullerian duct, its cephalic part and the horizontal part will form the fallopian tube. Okay, cephalic and horizontal part will form the fallopian tubes on each side. Then the two Mullerian ducts fuse with each other to form the uterus, cervix, and the upper third of the vagina. Of course, the septum in between will dissolve, making it one cavity. Okay, so we'll form the uterus, cervix, and the vagina, the upper third of the vagina. The lower two-thirds of the vagina develop from the sinovaginal bulb derived from the pelvic part of the urogenital sinus. Okay, okay. So this is the development of the fallopian tubes and the uterus and vagina. Okay, please look to this table to see the origin of the genital tract in female and its homologous in male. Genital ridge will form the ovary in female and testis in male. Genital tubercle will form clitoris in female and penis in male. Genital swelling will form labia majora in female and scrotum in male. Genital fold will form the labia minora in female and the penile urethra and the ventral aspect of the venus in male. Pelvic urogenital sinus will form the Skene's gland in female and the prostate in male. Mesonephric duct will form Gartner duct in female and vas deferens in male. Gubernaculum will form the round and ovarian ligament in female and will form gubernaculum testis in male. This is the last slide. Thank you. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura, universe.